All right, good morning, everyone.
Good morning.
All right, so let's see. Mhm. Okay, so we can share the screen here. All right, everybody can see this.
Yes.
All right, great. All right, so we have 1 hour, right?
Yes.
What?
Yeah, we do have 1 hour.
Okay. All right, so I think there are 4 things you can find in the lumbar disc degeneration disorders, and these are the 4 things. So most common is disc herniation, then lumbar spinal stenosis. Then you have a degenerative spondylolisthesis, and last is because of degeneration, because of a asymmetric collapse of the disc as well as a deformity of the spine and the facet joints. This can create a spine deformity. So that's called either degenerative spinal deformities. So if we discuss first is a lumbar disc herniation. So it's the most common manifestation. Um, and as you know, everybody knows that the disc is nuclear pulposus in the center and then the fibrous annulus fibrosis in the periphery, which is basically a tensile failure of the annulus, and the pulposus can come out. The most important thing is this: if you're age below 60, almost 1/5 people do have this. And if you're age of more than 60, almost more than 1/3 people have this without any symptoms. So it's common to have this even in asymptomatic patients if you do an MRI. That's for the disc herniation. If you look for lumbar canal stenosis, if more than 60 years of age, almost 20% people do have this lumbar canal stenosis, not disc herniation. So, so stenosis and disc herniations also present in asymptomatic people. So you have to be careful what when you find this is actually really symptomatic or not by the patient's examinations and symptoms. Okay. So ask me any questions if you have in between. Okay. So this is the pathanatomy. Why disc herniations are more common posterolateral? So this is the reason why. So if you take out the lamina, so you can see this on this side. So these are the pedicles. There's a disc in between, and this is your posterior longitudinal ligament, which is a top structure. And so mostly the disc herniations comes out whenever it comes out posteriorly is usually on the other side of the posterior longitudinal ligament because you have a posterior longitudinal ligament which is very top structure. So that's why the posterolateral herniations are more common than the central herniations. So this is the this figure is more important because I think is you have to understand like what nerve can be affected and what locations this disc herniation is. So this basically you take out the lamina. This is your sacrum here. This is your L5. This is your L4. This pedicle is L4, right? So when the nerve comes out medial to the pedicle of L4 and inferior, that's your L4 nerve. The nerve comes out medial to the pedicle of L5 and an inferior is L5. So if you think about if you have posterolateral herniation of the L4-5 disc, the most common nerve is affected is L5, correct? So sometimes it's because you can see it, this is your nerve comes out here and your dura is right here. So it's sometimes it's in the axilla of the L5 between L4 and L5 disc herniation. If this disc herniated and migrated upwards, that can be affect L4. If this disc is herniated more lateral and it's in a foramen right here, that can affect L4. If this disc is out more lateral outside the foramen and herniate out, that can affect L4 as well. So it's even though it's L4-5 disc herniation, the different location gives you different kind of symptoms. But you have to understand like what locations your disc herniation is and what nerve is affected. Okay. So these are the zones like you that I mentioned. I can go from previous figure. So here the zones are here. So this is your dura boundary here, and one dura is here. So from dura to dura is your central canal. From lateral edge of the dura to the medial edge of the pedicle is your lateral recess. Okay. From medial wall of the pedicle to the lateral wall of pedicle, that's your foramen. And if you go outside the lateral wall of the pedicle, that's your extraforaminal. So this is the same thing its figure is showing you here. From here to here is the central canal. From this is your pedicle here. So here to here, this is your lateral recess. This is your foramen. If you go outside the pedicle, it becomes extraforaminal. So which is far lateral. Okay. So as I mentioned before, so this is the same thing. So this is your sacrum. This is your 5, 4, 3. If your disc herniation go up and it may be in your axilla, that can affect the alpha nerve root, even though that's alpha S1 disc herniation. So that's your axillary herniation there. If your disc herniation a little bit more central and is slightly more caudal than cranial, then it goes to the axilla of the bottom nerve root, or maybe on the shoulder of that nerve root as well. So that can cause the symptoms of the S1. So even though it's alpha S1, just a little bit, location is a little bit different. It's basically just above the disc or at the disc level, as your nerve compressions are different too. Okay. So this is how that happens. Like in order to have a disc herniation, you need a disc, right? So most of the old people, after so every disc degeneration usually starts at the age of 40. So older you are, you have more degeneration. And then you lost your disc height, you lost the disc, and you don't have a disc to herniate. Younger you are, you have a disc, so that can herniate through. So, so mostly younger people affects with the disc herniations rather than older people because they don't have a disc. Okay. So this is like multiple papers, like how disc herniation can cause inflammation, how the inflammatory nerve process and mechanical compression on it can make having a pain in the legs. So in order to have pain, you need a mechanical compression. That's number one. And then they also, like some of the paper says, like you do need inflammations around the nerve as well. So so there are multiple papers with the immune response. They check the elevated IgM level during the disc herniation patients and so far and so on. So this is the same thing. Other papers are showing that like there is increased inflammatory reactions, and around whenever you have a disc herniation, they find the level increase all the inflammatory markers. So now disc herniation can cause back pain. So there are whenever you have a posterior annulus rupture, the posterior annulus is actually innervated by the nerves. So that can give you a discogenic pain and increase substance P in the degenerative disc. That was suspected due to the back pain as well, but literature is not clear in this. Okay. All right. So there are classification as morphological classification. So how you what kind of disc herniation it is. So whenever you have a disc herniation, like it's caused a protrusion outside the disc. So that's a little bit, but it's still contained into the disc. It's just a disc bulge. So that's called protrusion. Intrusion is like it's outside the nuclear pulposus, but there's some part of the disc is still inside the disc. And then sequestered means it's outside without any connection between the disc herniated portion. So the disc completely nucleus pulposus is completely out without any connection to the part of the disc. So that's called sequestration. Okay. So there is another classification by location as well, as we discussed before. There's a central disc herniation, then posterolateral means the lateral recess, foraminal and extraforaminal. So usually the history of the patient is this. So most of the patient I see the disc herniation is sometimes it just starts like itself. Like they told me like, oh, I was sleeping the whole night and the next day morning when I woke up just started having a pain. But some patients do present with some kind of like trauma or twist, or so they pick up something heavy, or so there is something before. So some patient complains about axial back pain and radicular leg pain with the dermatomal distributions, of course. The pain may be burning, dystastatic, or sciatic pain. Increase with the coughing and sneezing, of course, because your duration increase because of your disc herniation. Decrease by lying down, and knee and hip flex because your nerve can relax. And sometimes it's developed with some weakness as well, depending on what kind of nerve is affected. You can ask for valvular functions. Social factor is important. Work history, pending litigations, L&I case, that also important just because, not because of a pathology, because like how much the patient gonna get better after the surgery. On physical examination, you can find, you can check the gait. Uh, that can be changed with the, because just because of pain, that's number one. But also, so some of the patient develops a weakness if you have L5 nerve root compression that can cause your hip abductor weakness. Then you can find Tender-Lindbergh gait. You have L4 nerve weakness, then you have an ankle dorsiflexion weakness, then you can find foot slapping gait as well. So it depends on what kind of nerve is affected. You can find that on exam. Um, then you can check the neurological examination as routine. Okay. So SLR test is important. So this is more important. So why SLR? So whenever you have a disc herniation, so every nerve has it can glide up and down whenever you move your legs in an arc. So that can have so it's whenever you have a compression from the disc, that nerve can stuck to that level and then lost the capacity to glide up and down. So basically, what you can do when you raise the leg by 0 to 35, you can you can taken up all the slack in the sciatic nerve in your leg. After 35 to 75 is actually glides in your spine. So if you have a disc herniation and your nerve is stuck there, then that creates a pain in your leg. So from 35 to 75, most of the patients have pain from the SLR. And after 75, you cannot have further deformation. So basically, when you do SLR, some patients just, even though you move just a little bit 10 or 20 degrees, and then they hear like, oh, I have a pain, that I think that's malingering. If your pain is 35 to 75, that's probably the real one. So it's important to know like 0 to 35 usually has no significance if you have pain there. There's another thing is cross SLR. So sometimes when you try to move this, so other side of so if you do this on the normal side, the nerve which is stuck to the right, suppose you have a disc herniation on the right side. And if you raise the leg on the left side, sometimes that creates a tension on the other side as well. So that's called cross SLR, which is more specific and sensitive because if you have a cross SLR positive, that patient gets better pretty good after the surgery. So what kind of imaging you can do? Of course, you need a plain X-rays with the flexion and extension views, and the MRI is always a gold standard to diagnose the disc herniations. Previously, people, this CT myelogram is important too because there's so many people that you can see in a clinic that you cannot get an MRI. MRI is contraindicated. So at that time, you can do CT myelogram. So discogram is a different thing. Is a historic value. If previously there was no MRI, people used to do discograms that they inject the dye in a disc in the nucleus pulposus, and on which the dye comes out from the nuclear annulus fibrosis defect. Then you can find out, okay, this is the disc has a disc herniation, and then you have to correlate with the symptoms as well, and you have to do discogram on multiple levels to find out which disc has annulus fibrosis defect. That makes sense. And then you can take X-rays, so you know that this is a disc has annulus fibrosis defect. But nowadays the MRI is the gold standard, and an X-ray is the first line of investigation. Make sure there is no instability on a flexion extension, whichever the level you have a disc herniation. So natural history. What happens if you don't do anything? So almost 90%, any paper you can take for natural history of a disc herniation, almost 90% people gets better by itself. So you have to just assure the patient when you see within the 6 weeks of the symptoms. I usually tell the patient, unless there is the acute issues, 90% people gets better by itself. So you have to just patient with it, and then you have to wait and watch the patient for at least for 6 weeks. So what you can do meanwhile during that 6 weeks of time, you can try to do the bed rest just for 2 or 3 days, not more than that. If patient has a severe pain, then you can start a physical therapy. So usually it's a core strengthening and all the educations. You can try to as much as possible you can help with the pain with the physical therapy, and you can try some pharmacological therapy like anti-inflammatory pain medications, narcotics, Tylenol. I mean, most of the people take Tylenol, but they don't take a right dose. If you really want to treat pain and patient takes Tylenol, try to give them at least a full dose of Tylenol, because if you have pain, if you're not taking pain medication on the right dose, it's not going to work. So most of people don't take Tylenol at the right dose. So that's where you have to be very careful to make sure they take the right dose. Is the 1,000 milligrams every 6 hours, so that becomes 4,000 milligrams a day for the adults. Okay, and then oral steroid can help as well. That's actually tremendous help if you do meteral dose pack. What next? If patient don't get better with the PT, this is a epidural steroid injection is also an important step um, to do the conservative management as well. So most of patient gets better. So this other paper shows that almost 70 to 85% people gets better with the epidural steroid injection, and they did not require any surgical interventions. So what next? If patient don't get better within 6 weeks, if you're a patient with cauda equina, if you're a patient with the weakness, you're a patient in the ER that you cannot discharge because of pain, or patient has a severe pain. So these are the indications you can do operations. Then the results with the operation versus non-op is also convincing. Like if you do surgery, the patient do well as well. So this is the first paper that actually compared operative versus non-operative, and they have a long-term outcome. So at 1 year, the surgical patients has a less symptoms. So almost 71% patients has a relief as compared to 43% of the non-op. At 5 years, 70% reported back pain and leg pain improvement as compared to 56% is non-op on this paper. And at the 10-year is almost about the same. If you can see, is a 69% is operative group and 61% is non-op group had an improvement in back and leg pain. But most important part is this. So you can see that 25% patients in each group at 10 years had a one more lumbar surgery. Means if you started non-op, you ended up having a surgery in 10 years. You started with operation, you had another surgery at 10 years, is like 1/4 patients. So basically, reoperation rate is 25% in 10 years. So these are the indication I already talked about, like what indications you do operations, and how you do operation is also important. Um, People do with the simple open discectomy. You can otherwise try minimal invasive using tube system, which I usually do. And endoscopic is another method. Um, I think we have a surgeon in a UW. Uh, he does endoscopic as well, and he has a pretty good result with the endoscopic as well. So poor outcome predictors is also important. The patient has a mental issues, of course, and an L&I litigations are always having issues with the if they even they underwent the surgery, they're not going to have good outcomes. So these are the complications. So this, I think the sports trial is more important to discuss here. Then you have a better idea of what, I mean, this is most, I think, reliable paper because they have a randomized control trials. So what they started is this. So they select the patient and they initially want to do everything is randomized control trial. But as you know, when you have a patient with severe pain, it's hard to like convince them in a randomized control trial. So like if your patient with the severe pain comes in a clinic and then you're explaining, okay, we are doing this study, which is randomized control trial. So you might end up in a surgery, you might not. So that patient sometimes doesn't like it. So initially when they started, they want to do all the randomized control trial. What happened with their practicality of this randomized control trial, they find out some of the patients wants the either surgery or no surgeries either or. So they created the observational study. So what they did, they asked the patient if you want to underwent the randomized control trial or you want to do the observational study. Means you decide your treatment and we put you on a study and we compare non-op versus operative. So they initially enrolled 1244 patients, 501 enrolled in a randomized controlled trial versus 743 patients enrolled in the observation study. And then, as you know, like when you do this, there's always a bias, right? Because the lesser pain, they always gonna go into randomized controlled trial because they're not gonna care about it because it was like, I can try non-op, I don't care. So they are still in dilemma. While a patient you enroll in observational study, they have a strong feeling what kind of treatment they're gonna need. That makes sense to you guys, right?
Yes.
Yeah.
Makes sense.
Yeah. So this is what happened. So so now out of 70, so observational studies that they find out of 743, they actually choose a surgery, like almost 2/3 patient needs surgery, right? And probably the 222 patient has a lesser symptoms. They initially do not want to get the randomized control trial because they know that they do not want to undergo surgery. So that's why they choose observational study. So that will always create a bias, right? So at the 2 years, this is also important. So at the 2 years, um, 96% underwent the surgery group, and then 22% underwent the surgery at a non-op group. So almost, even though they initially choose non-op, one fifth patients already had a surgery by that time. And 96% is pretty good because once patient wants the surgery, they underwent the surgery. That's actually nice. So So this is what happened, right? So now, so this is their operative data, and this is the reason I put this one is important that you can discuss with the patient when you are in a clinic. The 7% has a reoperation at the 1 year, and 9% had a reoperation as a 2 year, and only 2% patients as a dural tear. So dural tear is really, really low. If you operate like 100 disc herniations, you can have only two. So this is the two things I think it's important to discuss while you're in the clinic. If you want to say to the patient, like, okay, only 2% is dural tear, and then reoperation is 9% at the 2 years. So what they did is they have every sports trial anywhere you take out, like you do disc herniations, you have a lumbar canal stenosis, and you have a degenerative spondylosis. So they have a primary outcome and they have a secondary outcome. So primary outcome includes your body pain, so basically visual analog scale, physical function of SF-36, and ODI, I think ODI disability index. So, and then secondary measure is a sciatica bothersome index, satisfaction rate, and self-rated improvement in the patient. So these are everywhere, like all the sports trial. They have this primary measures and the secondary measures. So, so for 2 year lumbar disc herniation, that favors primary outcome at 3 months, 1 year, and 2 years. Secondary measures also got improvement. So when you underwent the surgery, primary and secondary, both outcomes are better at 2 years from the lumbar disc herniation. So the conclusion was both group actually improved, but surgery had a better reported outcome. Okay. So that's the conclusions. So now they follow the same patients at 4 year. So this is what happened at 4 year. So if you can take a look, when you underwent a randomized control trial, so there is a randomized, like you randomized patients for the surgery. That doesn't mean patient underwent the surgery because you need a patient's consent, right? So that's also a problem with the randomized control trial. So what they did is they decided 501 patient gonna get randomized control trial, and they decided this part of half patient gonna get surgery, half patient not gonna get surgery. So which are the patient they decided the surgery? Only 59% underwent the surgery by the age of by the 4 year. So that's also important when you do randomized control trial. You decided, okay, this patient gonna go in surgical group, this patient gonna go in non-surgical group, but still they're not gonna get the same thing. So still they have a surgery or they might not have a surgery. On the other hand, when you decide this patient not gonna have a surgery, almost 45% patient had a surgery in that group. So that there is a lot of crossover and overlap while doing a randomized control trial as well. That also created the issue as well in this study. So that we can discuss it later a little bit. So at 4 years, so observational group is same because you already have a like patient at 2 years, 96% already had a surgery who decided to have the surgery. The same thing happens at 4 years. It's the same patients. So if you combine both the groups, almost 65% underwent the surgery and then 35% remain non-op. Okay. So this is there during the surgery, what you can discuss. Only thing I don't understand, so this is another thing, the dural tear rate a little bit more than the last time, and like 1% higher. I think the more patient added after 2 years. The reoperation is important. So at 4 year reoperation is 10%. So 10% people need same surgery again at the same level. So this is how they decided to do. So what they did is they divided to two type of analysis. Is one is intent to treat, means you decided this person has a surgery, even though the patient don't have a surgery, they are in a surgical group. You just assume that they had a surgery, and you compare the surgical versus non-surgical. Okay. So what happened is At 4 years, there is no statistical significant difference in the primary outcome. It was in secondary outcome, it was statistically significant and favors the surgery at 1 year, that also maintained it out of 4 years just for sciatica bothersome index. So this is what happens. So if you take a look intent to treat analysis, you think is like there is no difference between surgical group and non-surgical group in primary outcome, which is the important part of the study. So now so once they have an intent, everybody got it, like intent to treat analysis.
Yeah, it makes sense.
So I repeat again, intent to treat is once they decided this patient needs surgery in RCT, they remains in the surgical analysis group. When they decide non-surgical group patients, they always remains in the non-surgical analysis, even though they have a surgery. And then they compare between surgical and non-surgical group, and there is no statistical difference in the primary outcome. So then they decided, all right, so now we do as treated analysis, means even though, so now you have a surgical group in RCT, like half patient went under surgery, but half not. So whichever the patient is non-surgical, you decided, okay, that's gonna go into the non-surgical analysis. And whichever the patients from non-surgical group had a surgery, they added back to surgical group. So now as treated means whichever the patient got surgery, they got surgical group. Whichever the patient got no surgery, they're gonna be a non-surgical group. So now they did the analysis again. That actually favors significantly to the surgery in both cohorts. So, and then that actually significantly favors the surgery for all primary and secondary outcomes at each point, means from all the way from starting 3 months post-op to the 4 years post-op. Okay. So, so then that was this is the conclusion of the 4 year. So who had a surgery that maintained the greater improvement in all the primary outcomes than the non-op patients? So so basically surgery do helps at the by the time of 4 years. Okay. So now they follow the same patients through 8 years. And this is more important. So now the reoperation rate is 15% at 8 years. So if you have same level, the same level surgeries within 8 years is 15%. This is also important to discuss with the patients. Some of the patients usually ask, like, if you have one surgery, how do you require more surgeries at the same level? So that this is, you can tell them there's a 15% time you need a surgery in the 8 years. So this is same again. So they also did the intent to treat and as treated analysis. So when you intend to treat analysis, there is no significant difference in primary outcome measures in both groups. As treated, the treatment is significantly favors the surgery for all primary and secondary outcomes at each point until 8 years. So if you take all together, like disc herniation patients, initially I thought like it was if you do surgery or no surgeries, like by the time the initial papers like published before the sports trial, they always mention this. By the 2 years of by the 2 years, if you do surgeries or no surgeries, the results are same. But usually, after coming the sports trial, is everything changed now? Looks like even after this, like 8 years, you have a surgery or non-surgical group, which actually favors significantly, statistically significantly on primary and secondary, all the measures at each point from 3 months to all the way down to the 8 years. So I think the surgery do helps the patient. Of course, once you have a surgery, your 15% reoperation rate at the by the time of 8 years. That makes sense. All right. So this is the, I think I put some cases here. And that's, you can see this, like you have a, say alpha hash one has a, so this is basically your MRI, right? And this is the disc herniation at the alpha hash one. And it's actually on a posterolateral side. What do you think, which nerve gonna affect it at this location? What do you guys think, which nerve is affected at this location?
S1.
That's one.
Yeah.
Descending nerve root S.
Yep. So that's correct. So this is the second case. All right. What do you think, which nerve gonna affect at this level? So this is 3-4 disc herniation, and it's right in the center actually. So what do you think, which nerve gonna get affected with this now, with this disc herniation?
L4.
Exiting.
What? Which nerve?
L4.
Central disc herniations are a little bit different because you can see like this is really, really central, and you cannot actually see any CSF at this level on axial cut. So which occupies the almost entire central canal and also compressing on the lateral recess because it's a too big of a disc. So that actually can affect the whole quad equina. So this, I think this patient has a quad equina. I mean, I just skipped this history. So you see this? So 2 days history of a left-sided EHL anchor dorsiflexion, so which is L4 and L5. And here as a first episode of the urinary retention with the S1 nerve roots, right? So they affected the whole quad equina. Because your L3 nerve root is already out at the L3 here, right at the L3, just below the pedicle of L3. So L3 not gonna affect it. So nerves we're gonna affect is L4, L5, and all the sacral nerve roots, which is consistent with the history. If you take like your EHL weak is L5, anchor dorsiflexion is weak is L4, and your urinary retention, that's your sacral nerve root. That makes sense?
Yeah.
Yeah. So this is case 3, and here you can see this is your sacrum, this is your L5 pedicle, this is your L4, and you can see there is a foraminal disc here, which now is affected with this.
L4.
Yep, that's correct. Any questions about lumbar disc herniations? What kind of questions you guys have for OIT for lumbar disc herniations?
It's a lot of testing of what nerve root is affected with each type of herniation, and then making sure that you know what each nerve innervates. So they'll give you an exam and show you an MRI, or they'll give you an exam and say, what is this consistent with? And just test if you know paracentral versus far lateral versus central.
Uh-huh. And I think I have so here is I have you can see this. You see this?
Yes.
So this is what you have affected when you have so S1 is plantar flexion. That's correct. Alpha is EHL. I think most of the people do this mistake on exam. When you have L5 nerve root, I think EHL is not a big muscle. If you're like ankle extension of the toe weakness, people don't even notice that, and it does not affect their life. But hip abduction is a big one. If you have a hip abduction weakness, and then most of the people don't do examination like neurological. How many of you like do when you do neurological examination check the hip abduction?
I think we always check their gait at least, so I think we would pick up on Trendelenburg gait.
Yeah, but sometimes patient has a severe pain, they don't want to walk.
Yeah, I think in the emergency department, we don't often check hip abduction.
Yeah, I think that's important because I saw so many times the hip abduction is weakness is actually that helps. The L4 is the ankle dorsiflexion weakness. That's your tibialis anterior. L3 is knee extension mostly. I mean, but knee extension is also overlaps with everything is overlaps. I mean, it's not a hard rule, right? L1-2 is your hip flexion. It's pretty rare to have disc herniation that affects your L1 and L2 nerve root because high lumbar disc herniations are extremely rare. L2 is your hip adduction. So these are the nerves that you can tear. That's one. What else they ask? Nothing else? I think
They
they
asked
asked
a
this
lot about the results of the
poor
sports
outcome.
trial that you went over. So just like who should get a microdiscectomy and things like that.
And this is also important. They also, I think this poor outcome. I think this is also important. The patient has a depression is a major thing. Sometimes somehow I mean older than 40 years old. I mean this is I think the more psychological issues the patient has, and then they have poor health, self-treated poor health. That patient not going to do well. I think they are mentally, I mean, depressed or something. So usually they don't do well. And then most important is the reherniation. I think that's the part I missed. The reherniation is it happens up to 5 to 6%, 7% of time, and usually the disc reherniation happens with if you're a patient more than 40 BMIs, like they have a high risk to have reherniations. And secondly, when they have a disc height is pretty big, means that disc has a lot of disc material. So you need a like when you do this first time surgery, you're obviously going to take out the patient's herniated piece, but you're also going to look for any loose pieces inside the disc space in a nucleus pulposus. You're not going to take out the whole disc. When you have more disc hernia, when you see the MRI patients in a pre-op, and if you see that okay, this patient has a pretty big disc height, yes, he has more material inside, and that might reherniate in the future. Usually that happens within a 6 weeks to 1 year. I mean, up to 6 weeks is pretty major if the reherniation happens, but that can happen up to 1 year. And then the patient has a heavy patients are more risk of having a reherniation because of their body habitus, and then they pressurize the disc more when you have more weight on your body. So that's reherniation. I have yet to see any patients with epidural abscess and then pyogenic discitis after the disc herniation. I didn't see it yet. Probably Carl and Transfer already have it because they are practicing for many years. Vascular injuries and bowel injuries. It's reported in the literature, means it's a case report. Like when you go into the pituitary, I mean, that's you can grab a disc, and then you don't know how deep you are in a disc space. Sometimes you can cause vascular injury, bowel injuries in front of uh, spine. So I actually talked to the surgeon who had a ball injury. The interesting story is this. So he was taking out the disc herniations part, and he didn't pay attention. So whenever I put any instrument into the disc space, I always keep in mind that how deep you are going. So usually most of the time, like when you are adults, from the posterior annulus, you can get up to 2.5 to 3 centimeter in, you're still in the disc space. So whenever you put any instrument in, you can take a look like how deep you can go, even though you don't need x-rays. So you can go up to 3 centimeters and still you are in the disc space. So what he told me that he was just grabbing stuff, and he didn't pay attention to how deep he was going in the pituitary. And at some point he had something came out and he thought like it was pretty interesting. So he sent for the pathology. And pathology report came back as a bowel.
That's
So that
terrible.
might happen. That's pretty scary. What else? Everybody read the sports trial. if you get chance, please read that papers. It's actually pretty good, and then you might have a more you might have more information from it. And now I think they're asking questions from the sports trial, which is common. Okay. I think we're gonna stop here. And if Jamie, if you can set another time so we can do the spinal stenosis and degenerative spondy at some other point, other Monday. Is it possible?
Yeah, that sounds good. We'll look into the schedule and see what we can come up with.
Okay. Whenever you have like any Monday is free, just let me know. We'll do Zoom. It's
Okay.
better to be on Zoom now, even though it's open.
Thanks very much, Dr. Patel.
Everybody's healthy.
Yep.
Any
Yep, thank you.
anyone with the COVID positive in our department you know of?
I don't think so.
Okay, great. Great.
Thanks, Dr. Patel.
Thank you.
Thank you,
Thank you.
Dr.
Thanks,
Patel.
Dr. Patel. Thank you.
Stay safe, everybody.
Yeah.